Tonight we'll have an interesting talk on the epilepsy. That's a SUDEP, sudden unexpected death in epilepsy, by Dr. Phil Smith. He's a consultant neurologist at Cardiff, UK. So I request Dr. Smith to begin with his presentation. So.
Thank you very much indeed. So it's a pleasure to be able to do this and to speak to people so far away without having to travel. So let's hope we can do more of it this way. So I was going to talk to you about the issue of SUDEP and epilepsy-related death, because really this is the most serious outcome and the most horrifying outcome of epilepsy. And it often leads to changes in people's service, optimized really on the basis of tragedies such as an epilepsy-related death. The problem is, of course, that it is often a quite unexpected death in a young person with a family, and so it's got terrible consequences, and it's something really that we should focus upon and try to make sure that the likelihood of this is completely minimized. So we will often, I think, try to help people's epilepsy, but we need to focus on those things which are likely to help the risk of SUDEP and try to prevent that. So just to give my declaration of interest, so I'm editor of Practical Neurology, and a couple of times in this talk I do mention articles from Practical Neurology. So I mention that really to recommend the journal to you rather. No, I think it's it's something that I do need to tell you about. So the talk is going to last about 35 minutes, and I would plan to take you through a case history first of all, talk a little bit about epilepsy-related death in general, and how we might address the risk of death in people with epilepsy. And finally, some words on our talking about SUDEP to patients, because it's very difficult. We all know that we should talk about this dreadful outcome to people, but in practice it's difficult, and we need perhaps some help with that, I think. So the case history I'd like to tell you about is someone of 28, and she'd had epilepsy from the age of 12, and initially they were infrequent, 3 seizures over 10 years, but latterly she was getting 1 seizure every 2 to 6 weeks, and these were major seizures, generalized tonic-clonic seizures, and they happened on awakening. This was the sort of epilepsy that was an inbuilt genetic cause of epilepsy. And quite appropriately, she was treated with levetiracetam, 1,000 milligrams twice daily. And in her seizures, she would have a convulsion, often with a lateral tongue bite, and afterwards would be drowsy and confused. And there was no history of absences or myoclonus or photosensitivity. So the background was that she had 2 young children. She didn't have any family history of epilepsy. She didn't drink excessively, just social alcohol. And she'd actually been seizure-free for 8 weeks. And she'd moved house the previous day, so things were all a bit disrupted, and maybe she'd lost a little bit of sleep as well. She'd woken at 7:30 that morning, and at 7:45 her husband had left to go and collect some furniture to put into the new house, and he returned at about 8:20. And when he returned with his father-in-law, the 6-year-old child was watching television downstairs, and the 17-month-old child was crying upstairs. And the husband and the 6-year-old went upstairs, and in the bathroom they saw the child standing in the bath crying, and the mother was face down on the floor, not responding. And the father rushed outside, taking the 6-year-old with him. The father-in-law came in, attempted cardiopulmonary resuscitation. Ambulance crew was called, and they tried CPR, but it was she was in asystole. And in the emergency unit, although she was in asystole, she was shocked a couple of times, intubated, ventilated, really, it seemed hopeless from the outset, and she was very acidotic, as you can see, very high CO2, very high lactate. It was pulseless electrical activity. She had a venous cut down and all this, and it was really a non-survivable insult, and really they kept her on the ITU only out of a kindness to demonstrate that everything was being done that could be done. And she was recorded as having died in that afternoon, 3:30 p.m., and a case was referred to the coroner. So she underwent a coroner's post-mortem, and at that she was found to have a bruise on her forehead where it was assumed that she'd fallen and hit her head on the bath. There was pulmonary edema, and she had a low serum levetiracetam, but this was a post-mortem sample of levetiracetam, which is notoriously unreliable. And of course, pulmonary edema is characteristic really of sudden unexpected death in epilepsy. Some 70% of people with SUDEP have pulmonary edema. So that was in keeping with this, and the history and seemed to tie in with this being SUDEP, sudden unexpected death in epilepsy. And I met with the family later, a month or so later, and it was clear that they had been unaware, they felt, of the risk of dying in an epileptic seizure. They felt that there'd been inadequate specialist access to us. I mean, it was not a perception that we shared necessarily, and we had perhaps discussed risk, but maybe not specifically the issue of sudden death in epilepsy. I think it seemed likely that she dropped her guard a little bit, having been seizure-free for 8 weeks, having up to then known that the worst time for her for a seizure was first thing in the morning, and normally there was close supervision of her for the first couple of hours of the day, but they were moving house and she'd not had a seizure for 2 months, and I think everybody got a little bit complacent possibly, and dropped their guard a little bit, and she had this dreadful outcome to a seizure. So, I mean, the real tragedy of SUDEP is that there was a widowed husband and orphaned young children, that the family was destroyed, and despite our perception as specialists, the message about SUDEP was clearly not getting through. We thought that we had documented and said that this is a risky condition to have, that we have zero tolerance for major seizures, etc. But still, her perception and their perception was that she'd never been told about the risks. So a few words then on epilepsy-related death in general. So epilepsy-related death, of course, the most common cause is SUDEP itself. And this is a tragedy through and through, strikes young people unexpectedly. But of course, there are other reasons why someone with epilepsy might die, and trauma and drowning in particular are important causes. Status epilepticus certainly is a cause of death, but this is rare, thankfully. It can have other outcomes which are bad as well. And the risk of suicide is also several times higher in someone with epilepsy and many other chronic illnesses as well than in the background rate. So overall, the risk is higher. But the other thing that can cause death in someone with epilepsy is missing an underlying cardiac condition that is misdiagnosed as epilepsy. So this is something that's more likely in an older person with ischemic heart disease who presents with a seizure, and it could be that the seizure is the result of a cardiac arrest, a ventricular tachycardia. So we need to think of that as well. But overall, the risk of epilepsy-related death is up to 3.5 times that in the general population. So the risk, so what about SUDEP itself then? What is sudden unexplained or unexpected death in epilepsy? Well, it happens in a person with epilepsy. It's a sudden unexpected death. And it's not necessarily with evidence of seizure. So there isn't always a bitten tongue or disrupted bedclothes or something, or someone having witnessed a seizure. In fact, the large majority of people with SUDEP are unwitnessed, and they're alone at the time they have their seizure, and that is a problem. So by definition as well, SUDEP is non-traumatic and non-drowning. Those two things can be excluded by post-mortem. But the post-mortem must also exclude any toxic or structural cause. But it's all right to have pulmonary edema. In fact, I did see someone a couple of years ago who had presented with pulmonary edema as part of a major convulsion. And he, after a night on intensive care, we adjusted his medication and he went home. And a couple of months later, he was admitted dead with a further seizure. I think it told us a very important lesson, that pulmonary edema is not just a side effect of a seizure. It is potentially an important marker of SUDEP, and needs to be taken very seriously. So the people who get SUDEP are often young, though it's rare in children. I mean, it could be that it's more common in the elderly than we think. We actually often, people who are older, maybe their SUDEP might get labeled as a cardiac arrest from heart disease or other conditions. So it's possibly underestimated that it could be an older person's condition. But in general, we think of this as being early middle age, or young and early middle age. So how common is it? Well, it depends really on the severity of the epilepsy. But if we think of overall with epilepsy, the risk is about 1 in 600 per year. So that's for pretty mild, ordinary epilepsy, someone with a couple of seizures a year, for example. So if we think of the prevalence of epilepsy being 1 in 140 in the population, we can therefore work out how many deaths you'd expect in your region due to SUDEP per year. So the incidence does vary according to how severe is the epilepsy. So someone with very good control, someone who's, say, driving and working and getting no problems, 1 in 1,000 per annum. Whereas if it's someone who is undergoing investigation for possible epilepsy surgery, they're getting severe and resistant seizures, then their risk may be as high as 1 in 100 per year. So 1 in 100 per year soon mounts up, as you can imagine. Now, after 10 years, that's a risk of 10%. This is a highly significant risk of SUDEP in someone who is bad enough to need an operation. So what can we do about it? Well, what is the risk in early epilepsy then, and what needs to be done about it? Well, there was a study called the MESS study, MESS study, the MRC Early Epilepsy and Single Seizure Study. So this randomized people with a first seizure or early epilepsy either to start medication straight away or to delay it until a second event. And what this showed in terms of SUDEP was that the risk of SUDEP was no different in the two groups. In fact, the only SUDEP that happened was in the group that started immediately with anti-epileptic medication. So there's quite some reassurance from this study that actually we're not allowing SUDEP to happen by delaying starting anti-epileptic medication. In someone with a single seizure, all other things being equal, it does not prevent SUDEP to start medication where you might otherwise not be wanting to start medication. So that's sort of some reassurance. And here's the actual data from the MESS study. You can see that that there were SUDEP was not related to not having medication. So but in the people with drug-resistant epilepsy, and this is an example of someone with lysencephaly or smooth brain, you can see very disabled and lot of learning disability. Their risk is significant, 1 in 100 per year. And if we think of people undergoing epilepsy surgery, we might, for example, discuss with them the risks of the operation. And we have an option grid as to like help them with their decision. This is one of the things that we might use. And they often say, well, this second row down, will the seizures improve? Yes, they will. And then the third column down, the risk is about 1 in 100 per year of dying if I do not have surgery. Whereas over on the right-hand side, third column down, if I do have surgery, about 1 in 100 might die in the operation. So actually, if you are bad enough to need an operation for epilepsy, then your risk of dying is actually higher year on year if you don't have the operation than if you do. So it's important that people fully appreciate what the risks of deferring the operation are. It is not without risk just to have epilepsy. No surgery, 1 in 100 risk every year. Surgery, 1 in 100 risk, one-off. The other thing about severe epilepsy is that there was a meta-analysis of various placebo-controlled studies over the years by Philippe Rivelin in France. And what this group showed was that in the, when you took all of the placebo-controlled studies that they could identify, that the risk of SUDEP was higher in the placebo group than in the add-on drug group. Not surprisingly, maybe, but I think this means that it's now unethical, I think, to do a placebo-controlled add-on study. If someone is bad enough to require to be able to be eligible for entering such a study, then they should have either low dose or high dose of the new drug, but not placebo. Placebo knowingly will increase their risk of SUDEP. So the other thing we mentioned just now, of course, was that other things can cause apparently resistant epilepsy. And this is a video of a young girl who is going to describe her blackout, because it turns out that it wasn't epilepsy that did it. So let's just hear her description.
Just take us through again one of these episodes. So say the third one that you had. Just start from the beginning with that. What happened then?
The third one.
Yeah.
This is when I drank the litre and the Coke. So.
A litre of what?
Litre of vodka and loads of Coke. So obviously I woke up in the morning with a hangover, and in the afternoon I felt like a nap. And then my brother came up the noises, and on this one, there was a long bang where I fell out of my bed, and my brother found me then in convulsion on the floor.
And what did he say you looked like? Okay, what did she look like?
She was shaking, her eyes rolling, and just noises like she's trying to talk.
Right. And that went on for how long?
The third one was like 5-6 minutes.
Was it? Okay. And were you sweating in that one?
Yeah, she was. Yeah. Okay, so I just turned the screen off for the moment. Don't worry. Just to say that if you heard that story, it's well possible you might have thought, well, that sounds a bit like an epileptic seizure, because I think I did when I first heard the story. But when we looked at her ECG, her ECG showed that the QT interval is significantly prolonged. And this was something that we knew already about their family because the mother had a diagnosis of long QT syndrome already. And so when this girl presented with seizures, there was always this likely possibility that she had long QT syndrome. But it sounded so like epilepsy that we actually did an MR scan of her brain first before putting in the implantable defibrillator, because we just wanted to be absolutely sure it wasn't epilepsy. But the bottom line is that cardiac syncope, even in a young person like this, can look just like epilepsy. The biggest trap, though, is in older people with ischemic heart disease who present with seizures, because there is quite a significant possibility that an older person with heart disease, that they actually don't have epilepsy at all, but might have ventricular tachycardia from a previous myocardial infarction. So we need to think about the diagnosis, but we also need to think about whether the medication is being taken at all, because people with epilepsy might well report that they're taking medication, pick up their medication from their doctor, etc., but not actually be taking it. So we can take a history from the patient, from the carer, from the parents, etc., and get some information from that. We can do blood tests, and note that in the case I described to you, the levetiracetam level was low, but actually that's not sensitive or specific, because post-mortem levels of levetiracetam are not reliable. But one thing that is quite helpful is to look at the level in the hair, because the hair grows on the scalp at 1 centimetre a month. And therefore, you can use the hair level of drug to look back retrospectively over the preceding 6 months, if someone's hair is long enough, to see what their adherence to medication was. And we did this actually in people with SUDEP who were in our service. And what this showed is that there was a lot of variability between the various hair segments in an individual, in those who died from SUDEP compared to controls. Controls are on the left, showing not much variability in their individual hairs, but in the people who suffered SUDEP, there was a lot more variability between the various segments of their hair, suggesting that at times they were taking the medication and other times they were not taking the medication. So quite an important clue towards this compliance or adherence as being an important factor for SUDEP. But actually, what is the cause of SUDEP? Well, it isn't one condition. There are likely to be different mechanisms. It is likely that it's either cerebral, the brainstem, the control of the heart and the breathing in the brainstem. It could be primarily ventilatory, and I think that's a very important cause, or it could be primarily a cardiac arrhythmia in some people. So there are various possibilities here. Certainly ventilatory. I mean, I believe that it might well be that people who have a SUDEP alone perhaps do not get the stimulation from an onlooker that they might get if they were with somebody else. If someone just shakes somebody and says, "Oh, you okay, you okay," that might be enough to start someone breathing again. Whereas if they're on their own, they might not get that stimulus. So I think that ventilatory is likely to be really important, but there are certainly cases who have been recorded as having cardiac arrhythmia due to the seizure, and definitely cases where the brain waves on the EEG have just gone flat as the result of a seizure. So this is a question for which I will tell you the answer, but the EEG finding in SUDEP, what finding would best predict SUDEP, and is it frequent generalized spike and wave? Well, you'd think that it might do. Is it photosensitivity at multiple flash frequencies? Well, it might be, and these are in alphabetical order, incidentally. Or is it the third one, post-ictal generalized suppression? And it is, of course, the last. It's the fact that after a seizure, you see suppression of the EEG. And if you see that to a large extent, then that person is more at risk of SUDEP than other people. So, for example, if we look at a normal seizure, a normal person, they have a seizure, and halfway along you can see that the waves are slow, but not completely suppressed. And it's, that's how you want it to be. You're going to survive that one. But if you have a seizure like this, where the EEG waveforms go flat, then this post-ictal suppression is much more likely to spell danger. And it can be that the EEG goes completely flat. You can see at the bottom the ECG tracing. This is still going along at about 60 per minute, but the EEG itself is completely flat. This is post-ictal suppression. And this is suggesting the brain is just not responding. And finally, this person's ECG stopped. This was one of these tragedies where a patient was recorded as having died whilst under the supervision of a hospital in a video EEG monitoring unit. So from the Mortimer study, this is truly a never event. We should never have people dying in hospital when they're being monitored. So another clue as to the possible cause of SUDEP comes from sheep, from a sheep model. And it's horrible to think of it, but what happens is that these unanesthetized sheep are put into status epilepticus using effectively ECT. And what happened in this study from 2003 was that there were a few benign cardiac arrhythmias, but the most striking feature was that when they were made to have a seizure, they would stop breathing. Their ECG would keep going. They would still have output, but they would stop breathing. And so, I think that this is probably the most likely reason why many people have SUDEP, is that they stop breathing as a result of the epileptic seizure. So that's what killed the sheep. In terms of addressing the risk of SUDEP, well, I've hinted already at what some of these risks might be, but here is the list really. The first thing is having major convulsive seizures. If someone is having generalized tonic-clonic seizures, then they are at risk of dying in a seizure. And as clinicians, we must have zero tolerance of this. We must do all we can to try to stop people having generalized tonic-clonic seizures. And if one drug doesn't work, we add another, and keep swapping them around and keep trying to stop those things, because they are dangerous. And people need to know they're dangerous. But there's these other things beginning with A. Being alone, 90% of people are alone. So if you can avoid being alone, then that's good. But a lot of people sleep alone, and that is a particularly dangerous situation actually if you've got bad epilepsy, because being asleep is also a risk for seizures. You're more likely to have focal seizures in your sleep. You're more likely to die if you're alone and asleep. And if you don't take your medication, then of course you're more likely to have seizures, more likely to die. If you've got epilepsy bad enough to need lots of drugs, polytherapy, then you are more likely to have a seizure that kills you. And if you drink a lot of alcohol, well, that could be because you forget the tablets, you vomit the tablets, maybe you perhaps have a more chaotic lifestyle, but in general, drinking alcohol is associated with SUDEP. And bottom on there is there an underlying other cause? Is there underlying cardiac disease? Because that's clearly a risk factor. And actually, if you had that and epilepsy, then perhaps you're more likely to die in a seizure, because a seizure might put extra strain on your heart. So in terms of what we can do as doctors to prevent SUDEP, well, I've mentioned we need to emphasize the importance of taking medication and help people to do that. And maybe advise them to have a little reminder on their phone or whatever, but one way or another to help them to take their drugs regularly. And we need to have zero tolerance for generalized tonic-clonic seizures. We must not say it's okay to have a couple a year. A couple a year could still be enough to kill somebody. So if they're still having those, then we should keep trying. And we need just to recognize the fact that sleeping, getting seizures in your sleep are dangerous. We can recognize it, but we can't necessarily prescribe people a bed partner or someone to supervise them in their sleep. And it's important at all stages, really, to be sure it's epilepsy. And I would recommend, actually, that you think about doing an ordinary, simple ECG for everyone with epilepsy, because, and certainly everyone with unexplained blackouts, but because you're looking out for undiagnosed long QT syndrome, HOCM, and ischemic heart disease. So that's what we can do. And we should keep coming back to it, and we should keep making sure that people are aware of the risks, because they can forget that they've been told. But what can patients do? Well, what patients can do most of all is take their medication. And you know, some people do not take it, but are too polite to say so. That they need to think about alcohol, because too much alcohol is linked to risk of SUDEP. So have a think about it, but they don't have to be completely alcohol abstinent, but be sensible about it. That regular sleep pattern is important for seizure control, and sleeping alone, well, you know, it's a difficult thing to raise, because you know, you don't want, it may be something that someone cannot do much about, but being alone when you're asleep is a risk. And carers, what can they do? Well, if they see someone in a seizure, well, they should put the patient in the recovery position, probably the tongue is falling forward, but attend to the breathing. Make sure that before they leave the patient to sleep it off, that the patient is breathing properly. Whether giving oxygen is helpful, I don't know, but whether alarms are helpful, we don't really know that actually, but the main thing is to make sure that patients are aware of the risk. And there is some work actually on alarms and checklists and so forth from this group here who wrote in Practical Neurology. I think what this does really, this checklist, is it just raises awareness and just makes sure that people understand that having epilepsy is not trivial, that having major seizures is potentially serious and even life-threatening. And so just by getting people to fill out a checklist can help their appreciation and understanding of this. So just thinking about talking about SUDEP as well, just how do we talk about it? Well, there is this paper as well from Practical Neurology, which I think it would be useful just to think about, because what they've done, what John Paul Leach and others have done here, is give us a few words that we might want to use when discussing this very difficult, sensitive issue of SUDEP. But I do think it's important to meet up with people after a SUDEP, meet up with families, try to help them to appreciate, well, it's perhaps too late then, but to help them to understand, and it will help them to come to terms maybe with things better, and to appreciate some of the broader aspects of it. But mainly it's about listening. When people come up to the clinic, it's about listening to their concerns. And when we give a clinic letter, we should send a copy to the patient and mention, I think, that there are risks associated with seizures. And perhaps the form of words that sometimes works is that I might put in the letter, people have even died during seizures. It perhaps understates it slightly, but it's important, I think, that people should have that information available. And trying to meet up with people is important. So that was really that. And so the take-home messages, ladies and gentlemen, are these really, that the main risk factors for SUDEP are having major seizures, generalized tonic-clonic seizures, of not taking the medication regularly, and of sleeping alone. These are the three things that most of all we should be advising people about and maybe attending to. And that really prevention begins with increasing awareness, not just amongst doctors, of course, but amongst patients. Patients need to know that this serious outcome is a possibility. And once they know it, then they will perhaps be more motivated to think about what can be done to try to prevent it. So thank you very much. I'm very happy to take some questions from you if you have any.
Nandan, you can also start your audio.
Yeah, I can. I've done that. Can you hear me?
Yeah, you and Anand can take the questions.
Yes.
Can I ask a question? Is there anything like we have near death? So is there anything like near SUDEP? I think you showed one patient who died while they were doing monitoring. But can somebody get almost SUDEP, and then can you make out from that is it more respiratory or is it more cardiac or whatever?
Yes, and of course there was the case, the young boy with juvenile myoclonic epilepsy who had pulmonary edema as part of his seizure. So I suppose he'd had a near SUDEP as well. But yes, I think there are many people who have a seizure that is so severe they might have a cardiac arrest and yet come round from it. So I agree, they are at higher risk of SUDEP happening in future seizures. So it is important, I think, very important to take that sort of thing seriously and do all we can to prevent further seizures by adherence, by awareness of the risk, but most of all making sure people take their medication.
Okay, we'll go to the next question. Phil, can you stop sharing your screen so we'll see you bigger?
Yeah, there we are. Okay. Can you see me now?
Yes, thank you.
Yeah. So
Right.
Professor Phil, thanks a lot for doing this excellent practical talk for us. And you know, there are a lot of questions coming up. Dr. Srikanta Swami wants to know, is there a relation of SUDEP with the frequency of seizures? Like, for example, we see patients who get seizure once in 6 or 12 months interval, sometimes despite very compliant medication. So is it related to frequency, or is it related to the type of seizure? Are certain types of seizure more prone to get, as you said, generalized tonic-clonic?
Well, I think it's the type of epilepsy and the type of seizure. Yeah. So I'm not so sure. Well, I mean, frequency of seizures, yes, but if it's frequency of generalized tonic-clonic seizures in particular is the problem. So people with Dravet syndrome, for example, are particularly prone to SUDEP, so it seems. So it might be that the underlying channelopathy that leads to Dravet syndrome, this is in babies and children, but increasingly seen in adults as well, they have a very high risk of SUDEP. So it's not so much the frequency as the severity of the seizures, I think, that is the concern. So a routine question might be to ask people if they go blue in a seizure, and that I would regard as a marker of something a bit more serious, and if that is happening, then we would try that much harder to prevent seizures altogether. But I don't think complex partial seizures, temporal lobe seizures, I don't think there's much risk of dying in those, even though some of them are associated with cardiac arrhythmias, mostly tachycardia and bradycardia, but not much risk of SUDEP, I think.
What about
So
non-convulsive seizures? What about non-convulsive status epilepticus? Those can cause.
So that's
seizures?
a good point, actually. Yeah, I think that if there is non-convulsive status epilepticus, then I think that could well affect the heart, and often people with that are quite ill from other reasons, and sometimes in the elderly in particular with non-convulsive status, then they may have underlying cardiac conditions. So I think the the prognosis there is quite poor, and they may well die from those seizures, but perhaps it's the secondary consequences of them on the cardiorespiratory system. In children as well, I presume that that would also be a dangerous situation for them.
So pulmonary edema is pretty common in the autopsy findings. And there are several theories. There is a cerebral theory, there's a hypoventilation theory, there's an autonomic imbalance theory, and so on and so forth. But what causes the final event of pulmonary edema?
Oh, I don't know. No, I'm sorry, I don't know. But no, I just recognize it as a common thing that
terminal event. Yeah.
A common event that it could be easily misinterpreted by relatives and families, but as being primarily a heart problem or whatever. But I think we recognize it as part of SUDEP. So I'm sorry, I don't know the cardiac physiology, actually. I defer to you on that.
So do you recommend counseling about SUDEP in all patients of epilepsy? And if so, and during what time? So when should we discuss about the SUDEP?
Yeah, well, I don't think there's any hard and fast rules. I mean, in the UK, we are encouraged to talk about it at the very beginning. I'm not sure whether that's always the kindest thing to do, actually. But, we hear from families, or bereaved families anyway, that they wish they'd heard about it at the very beginning. What I tend to do is to talk about risk with everybody. And then we discuss ladders and scaffolding and baths and carrying babies, and we just think about risk. And from there, it's easier just to mention that some people, they've even died from seizures. But I would not necessarily be one that advocate everybody hearing about death in epilepsy at the first consultation. I think it's something that needs to be revisited. But I would rather talk to them in terms of risk.
I mean, I would be worried about the parents staying up all night if once you tell them that there is a risk of death. And because they are worried, even without knowing about risk of death, sometimes the parents stay up and are worried that would he get us fit in sleep. So if we tell blanket everybody, that would be a little difficult. So maybe we have to identify those who are at high risk. So really, maybe. Yeah.
Well, I mean, if we really thought that staying up all night would help to protect them, then maybe that would be justified. It's just I don't think it would help to protect them. I mean, I think if they have some sort of alarm or whatever and able to rush in the moment someone has a seizure and make sure they're breathing all right, then that would probably be enough. The trouble is that teenage boys in their bedroom who are making a noise, that's it's not fair to have the mother rushing in then. So I don't know. I think that it's very difficult. There isn't a right answer to this really, but I think just raising awareness is important, and so that people understand that having it, because some people, for example, would think a seizure in the sleep is a good time to have it because you're asleep and you're not going to hurt yourself and this sort of thing. But actually having a seizure in the sleep is a very bad time to have it, and you are more at risk of dying in that. So I think it's important that patients don't trivialize sleep seizures and take them very seriously and do their best to try to prevent them. And if they're not on medication, to encourage them to do so.
So there's a question from Dr. Manjari Tripathi in Delhi. Is having a lesion around in an autonomic eloquent area, does it increase the risk of SUDEP? For example, if you have an insular lesion producing seizures.
Yeah, so it's a really good question, and I don't think we know the answer, actually. I think that it's not clear at all whether those with cardiac arrhythmias during seizures, so-called ictal arrhythmia, whether they have a higher risk of SUDEP or not. I mean, there are studies where people have had pacemakers put in and implantable defibrillators and so forth, but there's no clear evidence that this is justified. So it's absolutely right that insular lesions are more associated with cardiac arrhythmia, including bradycardia, even asystole. But we don't know if that's just a quickly reversible thing or whether it really is associated with death. I think it's more likely that SUDEP is a breathing thing and is a central brainstem thing, rather than it very often being cardiac, actually.
Dr. Vikash Agarwal from Chennai is asking, what is the risk of SUDEP in post-epilepsy surgery series?
So I'm afraid it's quite high still,
Yes.
because many people have epilepsy surgery and continue to have some seizures. Very often, though, in hippocampal sclerosis epilepsy, the frequency of major seizures, convulsive seizures, is not all that high. I mean, people get very bad complex partial seizures, but unfortunately, even after epilepsy surgery has been reasonably successful, there still is a risk of seizures continuing, and it may not be as bad as 1 in 100 per year, but it's still there, unfortunately.
What about pediatric SUDEP? Is it more common in children? And is it commoner in a group? I know there were some studies in the UK by Sanders and others who looked at mentally challenged persons in institutions and did studies on SUDEP and standardized mortality.
Well, I'm perhaps not very equipped to comment on children, but I know that Dravet syndrome is particularly related to this, to do with the sodium channelopathy, and a lot of sporadic epilepsy, generalized epilepsy, may well be related to sodium channel disorders. So I think in a child with bad epilepsy who's got something like Dravet or related to Dravet, then their risk of SUDEP is higher, much higher than the general population. So, but I'm not a pediatric epileptologist, so I don't know for sure.
So we usually talk of green 2B mutations and SCN1A mutations in pediatrics, which have higher risk. Yeah.
I think SCN1A definitely does seem to be associated with SUDEP.
Is detailed cardiac evaluation needed, including 24-hour Holter monitoring in a refractory epilepsy patients?
No, it tends not to, actually. I think that we would always do an ECG, I think, and what we're looking for there is any underlying additional, coincidental almost cardiac disorder like ischemic heart disease, old myocardial infarction, that sort of thing. But a 24-hour ECG might not be very productive unless someone has a seizure, and even then it could be that not all their seizures lead to an arrhythmia, and so you could get some false reassurance from that. So, but certainly our current guidelines in the UK would not be to include a 24-hour ECG in those circumstances, no.
So having seen a post-seizure suppression on an EEG, how would you manage such a patient? Would you step up the antiepileptic drugs? Would you add newer drugs?
Yeah, I think you try that a little bit harder, actually, to help them to control them. I mean, it's not something we can do anything specifically about, apart from ensuring that they are on a medication that suits them and a high enough dose, and that they are taking the medication. So, but if you see that they are in a higher risk group because of the post-ictal suppression, then I think it would just make us try that little bit harder.
Any medicines are related with SUDEP?
I don't think so, really. I mean, it was said originally that lamotrigine and carbamazepine, sodium channel drugs, might be related, and there were a couple of retrospective studies that suggested that. But no, I don't really see that. I mean, there are drugs that prolong the QT interval, of course, including antipsychotic drugs, but whether they really increase the risk of SUDEP, I don't know. I've not really heard that. So I think it's more about if you know someone's got a QT problem, then there are certain lists of drugs we must avoid. But I don't think SUDEP in particular is related to particular drugs, no.
What about substance abuse and SUDEP in a person with epilepsy?
Yeah, well, I think again, it's probably more the association of the chaotic lifestyle and the lack of sleep, and therefore provoking seizures and forgetting medications and that sort of thing. I think even people who take cocaine and amphetamine, I'm not certain that necessarily is going to make them more likely to die in a seizure. It might make them more likely to die for other reasons, a bit like alcohol does. But it's the sort of thing that probably will never be studied either, being an illegal drug. So maybe in rats.
Mm-hmm.
All SUDEPs are preceded by seizures, or they can happen without seizures also?
Yeah, well, I think that they're all in people with epilepsy, but the diagnosis can be made in someone without evidence of a seizure having happened. It can just be inferred that it must have happened. But at least half will have a tongue bite, for example, or will have got disrupted bedclothes if they've had a seizure in their sleep. But you don't have to have that. You've got someone who's found dead in bed, who's got epilepsy, and they got pulmonary edema, then that might be enough to say, well, this is almost certainly SUDEP.
So what about pregnancy and SUDEP? Because we often get childbearing age women coming to us who have juvenile myoclonic epilepsy, frequent generalized tonic-clonic seizures. We avoid valproate, which we know is a good drug otherwise for generalized tonic-clonic seizures and myoclonic. And then a lot of epileptologists have presented cases where they didn't put them on valproate and the patient died, kind of stuff. So what is your take on pregnancy and SUDEP, and how should we approach somebody who has a large number of generalized tonic-clonic seizures in pregnancy?
Gosh, okay, well, I agree with you that actually a danger time for women is when they are pregnant, because as you rightly say, they cannot take the drug that's best for the epilepsy, which is valproate, if they've got a generalized epilepsy. So it's disastrous really in that situation. And we do know actually that about 2 out of 22 women, it was in our study, we did a hair study on pregnant women and found that actually they had stopped their drugs in about 10% of cases without telling their doctor they'd stopped the drugs, because there is naturally a fear that the drugs may harm the baby, and so, but they may be too embarrassed to say they've done that. So there's that risk as well. I think that we just have to help people to understand the importance of taking the medication in a pregnancy, and try our best with levetiracetam, with lamotrigine, with we use zonisamide a bit more nowadays as well, because there seems to be reasonable evidence for safety in humans on that, and clobazam as well, but everything short of valproate really. I think there isn't really a time in pregnancy where valproate can be used. Even late pregnancy, the brain is still developing, and valproate would be a problem. So I think that we just have to try that much harder in people who are pregnant, and making absolutely sure that they are taking the medication that's being prescribed, and that everyone appreciates the risk to the person, and if they go blue in the seizure, trying to stay with them until their breathing is normal again. If you have patients like that, then that's very, very difficult.
So is there a genetic susceptibility to SUDEP, or is it familial?
Well, I think that there must be, but I don't think it's been discovered as yet. There are rats, I think, that have noise-sensitive epilepsy, but that's perhaps more long QT related, but they have epilepsy as well, and they will die if a loud noise is given them and this sort of thing. But no, I think if there is a gene, it's going to be an SCN1A type related gene. It's going to relate to the sodium channel.
Benign epilepsy syndromes are also at risk, like Beck's or Rolandi?
I don't think so, actually. I think that there might be an individual patient with very severe Beck might be you can't help feeling that they occasionally get generalized tonic-clonic seizures, and therefore they might be at increased risk. But in general, no. I mean, benign epilepsies generally are benign for that reason. So there have been the odd case of Becht who's died from SUDEP, but that's thankfully very, very rare.
That also holds for febrile seizures in children, I guess, because somebody asked a question.
Yeah. Well, I think, again, if it's just benign, simple febrile seizures, you really would not expect that to be associated with dying or any harm to the child. But of course, some febrile seizures happen in people with sodium channel disorders, and that they would therefore be at risk. A prolonged focal febrile seizure might be at risk of leading to problems. But again, I'm speaking outside my comfort zone here. I deal with people who are sort of 16 onwards.
Any other questions, Anand? Sudeep?
Any sex predilection for SUDEP?
I don't think so, though perhaps usually men mostly, when it comes to sudden death, are more at risk. I don't know whether that's because they are perhaps less likely to take their medications or drink more alcohol or have more chaotic lifestyles. I don't know, but I think perhaps being a man is more of a risk.
So I know there are seizure alert dogs in the UK and in the US. Why do people use seizure alert dogs?
Why do they?
Yeah, why do they use keep a seizure alert dog?
Well,
is it anything to do with the fear of SUDEP, or it is just to get a
I think the
sense
people
of aura?
The people that use them really believe that it helps, and the dog can detect the seizure happening long before it happens, a minute or so before, by some change in the smell. Maybe that's true. I think it's quite helpful people with non-epileptic attacks find it quite helpful as well, I think, but you can imagine that if you have a dog who comes and licks your face during a seizure, that might be enough to make you breathe, actually. So I'd be all for it, actually. If somebody said they wanted to have a seizure alert dog, that's great. But we haven't got the evidence. There's no nice guideline on seizure alert dogs. But I think if I had epilepsy, I'd be quite interested in having a dog who was going to lick my face if I had a seizure, rather than run outside frightened.
Do you really think that the dog can detect a seizure hours or a long time before? I mean,
no, I don't know. It may be a minute or so before, because I mean, things do happen a minute or so before. We see changes in the heart rate, for example, a minute before the EEG change. So I think there are things that happen to people's physiology a minute or two before a seizure that may be detectable by a dog. I don't know, but that's what the theory is. But no, I don't really believe that myself.
Okay, before we stop, I want to ask, how many of you three have had a patient of SUDEP?
We've had 3 sudden deaths. Unfortunately, it's very difficult to get them to do the coroner's postmortem.
But you've had 3 sudden deaths.
But for no other reason, they just were found dead.
Okay. And may I ask the participants, we have 200 plus, can the ones who have had SUDEP on them, a sudden death, I mean, I can't call it SUDEP, a sudden death, how many have had? Can you raise your hands? Quite a lot, huh? 13, 14, 20. So almost 10% or more.
The only problem is, unless we do a PM, we really don't know whether it's a SUDEP or it's death related to something else in a person with epilepsy.
Probable
SUDEP. How many people advise or tell their every patient of epilepsy that there is this risk of SUDEP, and you got to, it's like telling them, how many tell?
I would think fewer than half in practice, though if you ask them in a meeting like this, it'll be 100% say they do, because that's what we're advised to do. The NICE guidelines say we should discuss SUDEP with everyone at the start, but when it comes to it, the actual practicality of it, I find it easier and perhaps kinder to talk about risk and raise awareness of risk rather than necessarily talking about SUDEP at the first meeting. I think that that might drive someone away and make them so frightened by it that they wouldn't want to engage again. So I think it's something that someone with, once you've established that their epilepsy is poorly controlled and they're getting major seizures, and particularly if you feel they're not taking the meds, you suddenly disappeared, then that would be good. Okay, it looks like I've been cut off.
Thanks a lot,
Okay.
Dr.
Right.
Phil, for
Okay.
being here and giving us a fantastic talk on SUDEP, as
It's
usual.
been an absolute pleasure. I've enjoyed it. Thank you very much indeed for inviting me.
Anand, you want to say something?
Thank you very much.
Yeah.
No, I just wanted to share my experience for the counseling of the counseling for SUDEP. So just I'm sharing my screen.
Oh yes, okay. Oh sorry, that's what it was. I thought that you were moved on to the next
Is it
talk.
visible? Is it visible?
Yeah, it's visible. It's visible.
Yes,
Yes.
it is,
Yeah. So neurologists were interviewed, and I think the Indian neurologists, they gave the answers, which is tabulated here. They discussed the risk from epilepsy, but risk for the accident, trauma, or other things. In quite number of patients, more than 90% of epilepsy patients, they discuss the risk, which were other risks, but not the SUDEP. And hardly 10% of the neurologists discuss risk for the SUDEP. And the time for discussion was mainly when the epilepsy became the refractory epilepsy, not at the first time of the diagnosis or within 1 to 2 years. Once they feel that the epilepsy has become refractory, then only they discuss the SUDEP. Maybe just they want to know the good compliance from the patient. And the reasons for SUDEP discussion was again the refractory course, generalized tonic-clonic seizures, polytherapy. And reasons for not discussion is patient, the neurologist felt he is not at risk for the SUDEP. So the fear for emotional reaction, the poor benefit to risk ratio, no known preventive measures, lack of time, I think it's a main factor here, raising concerns in patient or caretakers, lack of consequences. So this was the study when the neurologists were interviewed. So majority felt it is to be discussed only if they feel there is a risk of SUDEP, when it is refractory or when the compliance is poor. And they are comfortable discussing risk, other risks than the SUDEP from epilepsy. That was the conclusion from the study.
Yeah, I mean, I think that's very helpful indeed, and probably pragmatic and sensible. That the discussing actual dying is targeted at those who have the major seizures despite medication. So that seems good practice.
Thank you. Thank you very much.
It's good practical guidance. Thanks, Phil.
Thank you, Anand. Thank you, Phil, and thank you, Anand. I think we had an excellent
Thank you, Sudhir.
session. Thank you. Good night.
Okay.
Good night.
Good night.
Be
Good night.
safe.
Thank
Be
you.
safe, all of you.
Yes.
Yes. Okay. Thank you then. Bye-bye.